What's going on? I'm Ethan Brown, doctor of physical therapy, certified orthopedic manual therapist, and fellow of the American Academy of Orthopedic Manual Therapy. I wanted to come on and talk about a treatment that I use commonly for inflammatory issues as a physical therapist when traditional manual therapy and exercise just really isn't getting the job done. Right now, I've got a subacromial bursitis on my right shoulder. I was doing some rock climbing over the summer, and as I was kind of navigating coming down, I went into a pretty deep extension, abduction, internal rotation position as I was trying to lower myself. And I pinched the subacromial bursa. I don't have any issues of the supraspinatus that I can tell. Rotator cuff is testing strong in all the planes. And so underneath that subacromial bursa of the shoulder, you've got the subacromial bursa, or underneath the subacromial space, you've got the subacromial bursa, and then you've got the supraspinatus tendon underneath. When that space of the glenohumeral joint gets approximated and the ball shifts up, depending on the position, you can pinch either or both of those structures. And the way I like to think about this is, when you bite your lip and then it swells, so you keep biting it. You don't have a lot of space in that subacromial space anyway. When the bursa and or the supraspinatus muscle is pinched and becomes swollen, that space is even less because it's filled in more by those tissues. So you're even more likely to pinch it. Not only that, but the inflammation and the pain inhibits the function of the supraspinatus. Well, the supraspinatus' job is to maintain this space as the ball pivots in the socket. So if that muscle isn't working very well and your deltoid fires, the ball shifts upward in the socket, pinching it more. So you've got two main problems. You've got a space issue where that muscle or the bursa is swollen, and then you've got a mechanical issue because the muscle starts to get inhibited that centers the ball in the socket, and so it's not functioning very well. And so, you can eventually overcome that with manual therapy where you're mobilizing the joint capsule, really trying to create as much space as possible, and then reactivating the rotator cuff. But it can take a really long time. And honestly, this is one of those situations where we ought to just probably throw a little Western medicine at it and either have our patients do a course of oral steroids or a good round of anti-inflammatory NSAIDs or something like what I'm about to show you, which is an iontophoresis patch with dexamethasone. All right, so let's take a look at what we've got here. We've got dexamethasone, and it's at 4 milligrams per milliliter. This is the concentration I usually like to use for my iontophoresis patches. We've got a little insulin needle to inject it, and then we've got these on-the-go therapy patches. I really like these. I like it's 1.3 milliliter in terms of the amount of fluid it holds. It's a 14-hour delivery. I've used the 8 and the 14-hour. I think they both work pretty well. So we'll pull out one of these patches. I'll show you a little bit more. And then we've got a bottle of saline that'll end up going on the other end of the patch. All right, we're gonna take a brief trip back in time to science class. I forget, probably physics. And we're gonna open up these patches. So it's got a battery pack, and we've got a positive and a negative electrode. So a negative electrode is gonna repel negatively charged medications or ions. And so what we're gonna do is when we're loading this up, this is positively charged. This is gonna go on the positive electrode. The dexamethasone is negatively charged, so it's gonna go on the negative electrode. And then there's a battery pack in here that will help the negative electrode repel the negatively charged medication through the tissue into the inflamed area that I'm trying to hit. Just in case you care to watch this, so positive. If you're doing this, you can just remember pink is positive, the saline's positively charged. We're gonna go ahead and fill up that electrode. Again, each of these electrode patches holds 1.3 milliliters of solution. So on the insulin needle, I'm gonna need a little bit more than 1 milliliter. And so just to be honest, when I'm doing these, it says 1.3 milliliters of solution. I actually put a little bit more in there. I don't really go purely off the measurement. I wanna fully saturate that pad. It ended up being a little closer to 1.4, so not really a big deal there. And then what we're gonna do is we're just gonna kind of put it directly on the tissue. So for me, it's on my right shoulder. And if you think about trying to get into that subacromial space, you can't really get, it would be ideal to put it right on top so that it's pushing that medication down into the skin, but it's not gonna go through the bone. So we've gotta kind of aim for just underneath that spot where maybe a little bit more of the supraspinatus tendon is exposed, and we're at least gonna be able to best saturate the area around the subacromial bursa where it's not going to be a direct hit because I can't like shoot that stuff into there. That's ideally where, you know, potentially sometimes a subacromial cortisone injection is a great option. But as a physical therapist, this is a really good tool to use. I typically come a little bit more around the backside. That tendon's a little bit more exposed there. That's why if you guys are ever doing ultrasound on the subacromial tendon, you ought to put the hand behind the patient's back. It rolls that tendon out a little bit more and you can get it right there if we're going for the insertion. But all we're gonna do, take these guys off. And again, you wanna place the negative patch right over the area that you're trying to hit. And so I'm gonna kind of go right there with it. And be careful when you're laying these down. Slower is better. Try to get as much of that stick on as you can. Nice. Not bad. So it feels pretty good. I can still move my arm around. 14 hours of wear time. I don't recommend showering with them. I've done it before. You're not going to get electrocuted or anything. Had to test that out. But I don't have a ton of confidence that the battery pack continues to work after you shower. It doesn't say anything about not doing that in there, but just common sense. I wouldn't put a battery in the water. So 14 hours, no shower. And usually I'll do 5 of these patches for like an episode, but it is honestly pretty like anecdotally clinical based, like as the patient's coming in or as I'm doing this. Ideally, I would love to knock down about 10 to 20% of the symptoms per patch. And that way, if I'm 2 to 3 patches in and I'm not even near 50%, I'm not going to keep going because I don't have a lot of confidence that this is touching it. So that's kind of the numbers that I use. That's just my experience and a little bit of subjective report there. But these are an awesome tool. You can get these online. And then if as the patient, you can, as a physical therapist, you can have your patient go into the doctor's office and get a bottle of dexamethasone for you to inject. They'll bring it into the clinic. You just keep it in here for them. And then you can administer these patches as needed. Or if you are a patient, you can do that and go to the doctor's office and talk to them about having your PT apply these. So just a cool option for inflammatory based issues that aren't responding to normal PT, exercise, ultrasound, etc. And yeah, hope that was helpful. Thanks for watching.